Hello and welcome to this oncological emergency podcast on superior vena cava obstruction. My name is Mohammad Farid Jabir. In this podcast, we'll be primarily looking at the etiological causes of SVC obstruction, the signs and symptoms to be aware of, as well as the investigation and management technique. The superior vena cava is the largest vessel that drains the head and neck and limbs and chest. It can be obstructed by nearby lesions, which when compressed develop collateral vessels as seen on the patient's chest wall. Three manifestations that lead to SVC obstruction are extraluminal, within the wall of the lumen, and intraluminal. Extraluminal causes could be mediastinal lymphadenopathy. Within the wall of the lumen could be due to a tumorous mass such as lung cancer, and intraluminal such as thrombi. Common causes associated with SVC obstruction are lung tumors, commonly squamous cell lung cancers, as well as non-squamous cell lung cancers. Lymphoma and breast is the most common metastatic tumor. Signs and symptoms to be aware of are dyspnea, which is the primary main complaint which the patient would be complaining of, and also superior vena cava syndrome usually presents more gradual with an increase in size or invasiveness, and that's when the following symptoms develop, such as facial and arm swelling, headache, venous distension of neck and upper chest. The patient might appear plethoric and cyanosed. This here is an image demonstrating significantly dilated superficial veins in the upper torso. This image demonstrates SVC obstruction in a person with bronchogenic carcinoma. The two images basically demonstrate the swelling of his face first in the morning and its resolution after being upright all day. Investigatory modalities involve a chest X-ray, a CT scan, and very rarely histology, which is done by way of transbronchial needle aspiration at bronchoscopy. This here is a chest X-ray demonstrating a lung tumor causing superior vena cava obstruction. This is a CT image demonstrating a tumorous mass in the right hilar region causing SVC obstruction. Management involves fitting the patient up, providing high flow oxygen, steroids, dexamethasone BD, a morning and an afternoon dose to prevent insomnia. Steroids are used to decrease the inflammatory response to tumor invasion and edema surrounding the tumor. In the acute setting, endovascular stenting may be carried out by interventional radiology to provide relief of symptoms within 24 hours. And radiotherapy plays a big role, usually providing symptomatic relief. And that's about it for this quick podcast on superior vena cava syndrome. We've covered the manifestations of SVC obstruction, the signs and symptoms, as well as the investigation and management involving SVC obstruction. Thank you and goodbye.